worked on this. Elizabeth couldn't make it for today's session. She's caught up with something else. So I'll try to cover some of what she has done. She's done the first half of the presentation. So in general, adult learning is different to what it was back in the uni days. So we process things differently as grown-ups. I suppose everyone in the room is that. It has to be delivered or processed in smaller packets than what you could do in high school, university, and college. So you need to kind of plan your learning in that way to gain enough from it. So just cramming a lot of information in tight sessions just before the exams often is not very fruitful at this stage of your life. So it has to be, of course, you need to have motivation to drive that and to absorb the information that you gain from that training. But you also need to have a strategic approach. You need to have a more context around that learning. So that is the reason why we often do things around cases. So looking at what sort of cases that you come across, what sort of patients or what sort of particular presentations that you see in your clinical work, and you try to incorporate that in your learning. So it has a context, so you retain that information a lot better. Okay, there's a lot of research about how your brain retains information and what is a more efficient way of retaining information. I used to look at this a lot because I want to get a lot back with minimum amount of input. There are people who would do a lot, would study a lot. I was never one of those, even in university, let alone later on. So I've done a lot of work in fine-tuning being lazy, actually. So this is some of those tips, actually. The other thing is you would need to kind of retrain how you approach a particular problem or a particular case, especially first years when you start up. Looking at a particular scenario, you would have to try and develop a more rehab-oriented approach, looking at the whole person, looking at how the disability or whatever the problem that they have, how that limits their participation to what they were doing before that disability, and how you can actually fine-tune to get them closer to that, if not identically to that levels. And that is the approach that you would need to kind of gradually develop. So some of that comes with experience, but some of them would be active thinking in those terms. And this is where constant discussion with your supervisors, with your colleagues is going to be helpful. Okay, because you might pay a lot of attention in some details, which may be relevant in the bigger scheme of things, but not so relevant as far as the rehab planning and discharge planning and getting them integrated in the community. So use your time and energy in the right direction from that perspective. Okay. Now, feel free to kind of step in and share any anecdotes, or it's not a kind of a one-sided presentation, this one. It's just what we thought would be useful. Okay, so some of the formalities from the college training perspective is you need to kind of tick off certain milestones, certain blocks. So those are mandatory parts of your training program before you get your letters. So module 1, module 2, then there are the external modules which you need to kind of go through, leading on to the fellowship written and the fellowship clinical exams. In between, you would have to go through long cases, roughly 2 in each 6 months of terms, with at least one formal long case assessment. So this is something that you need to kind of plan for and make sure that you're not cramming up towards the end of your year. So that is not a very good practice, and that is often leads to a disastrous long case. Okay, so you need to kind of be a little sensible in planning this and discussing the timing with your supervisors. Some centers have dedicated times where you can do long cases. Some centers you have to kind of have that arrangement done with your supervisors. Okay, so you need to take some initiative in planning that out and making sure you have roughly times kind of fragmented and distributed, pre-booked with your supervisors for that. Okay. Any ideas, any pointers with people who've been through a lot of long cases? What helps? Anything to share at this moment? Practice, yes, of course, that goes with everything. You need to have some practice run. Consults when you get and when you discuss that with your supervisor is a useful practice run. Also, seeing a new patient in a clinic, try to make it like presenting a long case and discussing it a little more formally. That will give you a reasonable degree of dry run towards a formal long case. Okay. There are a few additional trainings that is required. So FIM training is mandatory. So you need to try and get your FIM trainings done through your term. Prosthetic and orthotic courses is also something which has high value. So that is also something that you need to plan for. Upper limb and lower limb prosthetic courses are run. Sydney runs both of them. Then you have some in Melbourne as well. Sydney one is definitely a lot better than Melbourne. There's a bit of bias because it runs at Prince of Wales. Okay, now supervisors and the contact with your supervisors. Again, this is important to have an open and clear communication with your supervisors and making sure you have key learning goals identified and making sure that you gain the best out of that particular training rotation. So each training rotation has certain unique aspects of it. Okay, so you would be able to get that information from the previous trainees or from the supervisors itself. Try and ticking off all those boxes in your training term, because that's not something that is easily accessible in other training terms. So there are some very general things which you can access throughout your training program, but there are certain unique aspects. So that is something that you would need to turn and get it done. Okay. Now, with that also requires some planning and making sure that you have time set up with, be it at the allied health team or certain specific clinics. So you would need to plan that, and you need to kind of have the other registrar cover for you. So those sort of things would need to kind of work simultaneously. You can be an extremely diligent registrar who really looks after the patients very well, very good in organizing everything, but that is the service requirement of the job. Okay, so you need to also pay a lot of attention for the training requirements for your professional development, and that has to be happening simultaneously. Okay, yes, you do gain some training from the experience itself, but there has to be some active work done in parallel to that service commitments that you may have. Okay, so having that regular interactions with your supervisors is important, and making sure that you're ticking off your training goals. So if there are certain areas you would like to spend more discussions or more time with, make sure you have that designated, because it is difficult for the supervisors to exactly judge what your deficits are and what are the things that you would need to work more on. You might be having some strengths and you might not require much discussions on that. They may be pitching it at a fairly general level, okay, going through generally all sorts of information. You might require something a bit more customized, so that has to come with the discussions with your supervisor. So make sure you're having that on a regular basis. The other thing is having some degree of dedicated training time and study time through your work week. Either one-to-one with a supervisor or as a group. That is quite important. Of course, you have some of these training sessions like this one here, and there are some other opportunities which might be available in your local hospital, be it journal clubs or some clinical meetings that may be having. So make sure you're aware of that and make sure you try and make time to attend those. Long case assessments, again, as I discussed before, you need to kind of set time for that and ensure you kind of get it done in reasonable time frames rather than cramming up at the end. I'm not going to go into the details of how it works and how you exactly do this. Try to take up all the opportunities that you get to have dry runs, practice runs of that, and do it formally. There are some formal learning opportunities. We will be starting some Saturday sessions as you approach the exams, and this sessions, the last Wednesday of the month, will continue for the year. Try and have some groundwork done before you come into these sessions. Okay, if you come to it blindly without doing much homework, you won't gain enough, because there is always a degree of assumed knowledge which the speakers and people who come and present would assume that you would know some basics, and they build up on that. So if you're just coming up unprepared, you're not going to gain too much, and it's not going to have much of a residual effect. So once you're out in the next week, it's all forgotten. Okay, so try to do that in a more structured manner. Modules is also something that you need to kind of plan for very carefully. That can quickly come and bite you, and depending on what terms you're doing, you might not get much downtime in some terms. So you need to kind of evenly space out the time you spend on the modules, which that's very important. Okay. Study groups, yes, closer to the exams, I'm aware most people would form study groups. Try to have that done early on, where you can actually share discussions, practice certain sessions, even if it is not completely clinical. It could be just practicing essays, writing answers, and shooting it out to the other person to kind of review and critique. So that kind of keeps you in check as well, and prevents you from being very lazy. Okay, so the other person might have a little more going as far as initiative, or sometimes the initiatives drops in one individual, then the other person in the group might just pick you up on that. Lecture series of these sessions are available online, so make sure you kind of look into that. Most of the BNTB sessions are fairly carefully designed, and we take in a lot of feedback from the trainees before we plan out these sessions. So a lot of those information from what is there online on the faculty website is quite useful. So you might be reading a topic, just check, see if there is a presentation that was done. You just quickly skim through that presentation, and then you start your reading. So Wednesday session, as I said, come in with some pre-reading on the topic, so you know mostly what the topics are going to be. So just build up on that. And after you have finished with the session, try to expand on the reading. So if you read around this time, this particular topics, that will consolidate that information. Pick up all the informal training opportunities wherever possible. So there's always, yes, you're expected to have discussions in your ward rounds. So try to structure that discussion. If you're having or dealing with a particular problem, ask about why this treatment approach was favored to something else which you may be thinking, or something else for which there is evidence. So often there would be a line of thought in whoever is a consultant involved. That may or may not be the right line of thought according to your judgment, but there is some logic behind whatever the plan is. So try to understand that logic, try to understand that plan. You may decide to use that plan, or you may decide to stay away from that plan or that line of thinking. But whatever it is, you need to know what that line of thinking is. Okay. Allied health nursing inputs. So this is very valuable because they have been working in those situations, working with those group of patients for a very long time. So there is a wealth of knowledge that you can derive from that. So try to have discussions with your allied health team about specific clinical problems, or go into their learning sessions. So they will always have their discipline-specific learning sessions. So try to find time to attend that, or follow through a patient that you have actually worked up from the beginning through various allied health sessions. That will kind of give you some context about what sort of therapies are done with each patient, what sort of strategies are done to get them better. So the next time when you actually recommend something, okay, you need to go and work with a physio for this, you might be able to tell the patient exactly what sort of things you would be working with. Okay, so that often is useful information to prime the patient, and also to direct the therapist as well as to what are the things you would like to see happening. Each centers would have some specialty clinics. Okay, try to find those and try to attend a few of those. They are quite useful, and it kind of gives you a very unique approach to that particular problem. Okay, you may read 10 books on that topic, read 5 review articles, but attending one clinic, for instance, my first time in a falls clinic was really very, very useful. I had read a lot about falls and falls prevention and strategies of that, but how it's actually dished out for a patient and how it's actually delivered is completely different to what you think it is. Okay, so attending and seeing that and the information that is given out to that is extremely useful in practical scenarios, not just in your own clinical practice, but what you dish out in the exam. So we'll have scenarios, questions asked related to those scenarios. So you might be having a completely different perception of how you actually address that. And that comes across as very professional, and it comes across as that you know something about that. Okay, that's a very simple investment to really increase your level of functioning. There are a lot of webinars available out there which may provide you with a more easily digestible information rather than skimming 10,000 journal articles. This is something that might be useful. I'll touch on some of the resources later on. AAPMR, who has logged into the AAPMR website before? Show of hands. Okay, so American Academy, there's a lot of resources here. They have a couple of things, PMR Knowledge Now and Me. If you log in and they have links for that, it's a free registration for that. Most of the programs you are able to access, some of that you need to be members. And some of them are only for their residents, but that is not particularly relevant for us. That will be mainly the American system. So this is something which is very, very useful, and they have a wealth of information. They go through a lot of different things in a fairly simple, easy to digest manner. This is another version of the Me, which has a fair amount of webinars and videos and presentations on different topics. Okay, so not all of this is accessible, but a lot of it is. Okay, so that is my profiles. It doesn't have a lot of it because I haven't done much lately. But as you do things in there, it will make recommendations about what might be useful or what might be related to that, or what your interests are. So you can actually customize the page and the feeds that it gives you. Has anybody looked at this before? No? Okay. iCard. Show of hands who have looked at this before. A few. This is, there's a similar thing for brain injury as well. This is a Canadian group who dishes out information, which is essentially summaries of the current evidence base on various clinical problems. So this is related to spinal cord injury. There's a similar one for brain injury as well. Extremely useful resource. It kind of fishes through all the information, all the current research on a particular topic. It goes through a variety of things, both acute injury related as well as rehab related. And it kind of gives you a summary statement, and there are boxes with high yield, high evidence-based recommendations for that particular modality. So this is something which is very useful. Again, this is more spinal specific, but also brain injury. So MSKTC. So these are model systems in the United States. So there are several model systems identified there, which have additional grants to dish out more research and knowledge translation, actually. So there is a lot of evidence, but translation of that evidence to practical clinical practice is often difficult. So they look at the knowledge translation pathways. They also have useful resources in a lot of different things, so PowerPoint presentations and some reports, fact sheets. So this is also a useful site to look at. E-learning SCI.org, show of hands who have looked at that before. Okay, so the usual suspects are the people who have. Again, this is for spinal injuries in specific. They have resources for various disciplines. So tailor-made resources in a very simple way. You can assimilate a lot of information. So it's a good starting point if you just want to refresh certain things. It doesn't go into exceptional details about things, so that you need to kind of look at review articles or textbooks, but it's a good basic starting point for that, for spinal cord injury stuff. Similarly, Asia offers a learning module where you can actually look at neurological assessments and anatomy of the spinal cord physiology. So there's a free learning module there as well. This is mandatory for anybody who comes and does a Prince of Wales spinal term or rehab for that matter. Show of hands who has heard of this, ortho bullets. Okay. So for those who haven't, will thank me for actually recommending this. I've seen this evolve. When I was training, it looked a lot different. They have possibly had some funding infusion. It looks very professional now. So this is a bunch of cheat sheets all clubbed together, and now they make it look very professional. There's a lot of things there. It's primarily geared at orthopedics and sports injury and those sort of things, but there's a lot of things that are relevant to us. And even if it's surgical approaches, some of that it's useful for you to be aware of. So this is where you can actually get, okay, what happens in an ALIF? What happens in a total hip replacement with different approaches? You just click on that video, 5 minutes, you know what happens. You can actually explain it in simple terms to the patient. You can actually work out, okay, so these are the muscle approaches, these are the tissue planes that are affected. So this is extremely useful. Okay, so please bookmark this. I don't know what is there. I think this was Hippocrates. Hippocrates, people have heard of that. Hippocrates is kind of similar to UpToDate, slightly better. There's part of it which is accessible with membership. A lot of it is free, so that's a useful resource. It kind of goes through a lot of medical conditions and kind of gives you good summaries of each one of them. UpToDate is useful in certain aspects, actually. Show of hands who has heard about this. Okay, this will change your world. Okay, ReadCube is like iTunes for your journal articles. This is absolutely amazing. I'm surprised people don't. Have you heard of Mendeley? Mendeley? Yeah. This is Mendeley on steroids. Okay. So what this does is it will access all your PDF articles, everything that you have downloaded, you saved from review articles or on articles that you have saved. Let's say it's in one folder in your computer. What this will do is it will learn that, and it will make it look so much better, so much nicer, that you have the article, and it's all smart articles. So there are references which show up simultaneously on the right side. You can actually cite that reference, save the citation. You can go to that particular article at that point if you want. That opens up in a new tab. You have to register yourself. You have to put in certain things. So if you have a university access to a database, so let's say university library access, UNSW, UTS, University of Sydney is recognized. So it'll automatically give you permission to grant access of that article and save that article in your library. It's fucking clever. And so you'll have your own library. You'll have recommendations. It reads all the articles that you have saved already, and it can access that like Google. So you don't have to fish and search. Okay, where's that article which I thought of? So it'll access that for you. You can search from this. So instead of doing a Google Scholar search, you can search from this, and it will just click on that. It directly saves it in your library. Or you can just say, okay, I like this. I would like to read it sometime in the future. It'll do that as well. So it is amazing, guys. Please get this. In the free version, you only access it in one computer. Okay, and if you pay for it, it's tax deductible. You get it on your phone. You get it everywhere. So that database is accessible to you everywhere. And if you're writing a paper, if you're doing a research, you plan to publish something, this is amazing. It'll save so much time. Okay. Yeah, so this is what I meant. This is what it looks like. It also makes recommendations based on what is stored in your program. So if anything which is relevant comes out of what you have been reading, so let's say you have 10, 15 rehab related articles, then it'll kind of make those recommendations for you, and very clever recommendations. It has got an artificial intelligence engine, which kind of, the more it kind of looks at what you're reading, or also what parts of the article you're focusing on, what are you looking at, it generates those recommendations. It's extremely clever. Okay. This is another useful resource if you're interested in ultrasound or diagnostic ultrasounds, especially. So this has an app as well for both upper limbs and lower limb ultrasound. So it used to be free. Now they're starting to charge a little bit. And this is useful. Moving on ultrasound, Sonosite offers a free education services for ultrasound, and this is extremely useful. So Sonosite has an app called Sono Access. That's available both on iOS, I think, and Android. Now this has videos about certain interventional strategies as well as diagnostic strategies, and you may require to have permission to access this app, and that's a simple registration form which goes to the local Sonosite rep, and they'll give you permission just to make sure you're not some random person trying to access it. It has to be a medical professional accessing this. Okay, WhatsApp. Guys, this is extremely useful. If you have a study group, run one, and you can have real-time discussions about clinical problems and just exchange ideas. It's quite useful if you're not already doing it. Evernote, do people use Evernote? Show of hands. Just one. Google Keep, do people use Google Keep? 3, okay. Now, this is another thing that is gonna change how you take notes and change how you attend education sessions and lectures and conferences, okay? This is a one-stop shop where you can, I have actually shifted to this in the last few years. I used to be an Evernote user. This works better because it kind of uses your Google data cloud, and the data is available. It lists, you can have notebooks inside this, you can organize it the way you are. So let's say you're attending a lecture, you have a folder for that particular session or for that particular conference or workshop. You can take pictures, that goes into there instead of it's getting saved in your picture folder somewhere else. Those slides can be there along with annotation and notes you want to make on those slides. That will stay there along with any other things that you want to attach which is relevant. So it just stays as one educational resource. You can write or scribble notes as I have done there, and that will also stay there as well. So it's super clever. It's searchable, so you can search for it later on. So it doesn't get piled in that notes cabinet, in that gray folder you all have in your study. So this is clever. So start using this. Makes life a lot simpler. Okay, self-preservation. Again, this is important. You need to have some degree of strategies to work on yourself and keep yourself going. So me time is useful. Try to find some and make sure that you stick with it. Physical aspects of that. Again, this is me looking at how you can be lazy. There are some of my colleagues who are happy to cycle 150 kilometers in a week or spend hours doing exercises. I am not one of them. So the science suggests if you can do high intensity training, you can get away with 5 to 7 minutes of exercises daily, 5 days a week, and get enough cardiovascular output and the gains that you would get from the training equivalent to a half an hour to 45-minute exercise session. So there's research backing. I'm not just making this shit up, okay? So look into that and start practicing that. There is a 7-minute exercise app which is available free. You use that 7 minutes a day. I'm sure you'll be able to find, and it's got 30 minutes rest breaks in between, 30 seconds, sorry. NEAT is another clever thing. The science behind this is there are always, yes, of course, exercises will cause some degree of thermogenesis, but there are so many other activities where you can increase your thermogenesis. So taking the stairs or simple things, if you actively plan those things, you can almost quadruple your thermogenesis in those activities. So try to incorporate some of that in your levels. So standing up, for instance, during the day for a period of time. Nutritional side of things, of course, pay attention to your diet. I was just looking at Google Images. Most of my presentations are Google Images and just looking at those things. This was interesting as to how portion sizes have increased over the decades. So you're starting to have larger portion sizes. You don't necessarily require that, but it just has crept up. So you need to kind of keep an eye on portions. Smaller plate has a science behind it. Using smaller plate shrinks your portion sizes. Paula is going to touch on your nutritional side, which might have certain take-home messages for yourself as well, not just your patients. Okay, mentally, try to have some way of releasing the pent-up stress. Of course, there is a degree of stress that builds up. That's the line of work that you are in. You need to have strategies of making sure you're you release it appropriately, and you have a way of setting it back to normal. Mindfulness I found very useful. This is a very simple way of practicing it or using it in your everyday life. Again, this is a free app. Most of it is free. So try and use it. Okay. So you can time how much time you want to spend on it. So the minimum is 3 minutes. You can build it up as and when you need it. Okay. Okay. Any other ideas? Any other pointers? Anything else that people would like to share? Some of the senior registrars, what did you find useful practice for your training, Atif? One note. Nobody should be a paper person. It's not good for the environment. Okay. Any other pointers? Any other ideas, guys? Okay. We might wrap things there. And before I go on and hand the mic over to Paula, I would like to just get the feedback from the room. We have been toying around with an idea of planning a spinal masterclass of sorts. Would that be something that the trainees would interested in attending? So something which condenses the key aspects of spinal cord injury management. Yeah, that is what I would like to get some feedback. What form would be useful? Would it be something like a week-long course, or a weekend course would be preferable? Atif? That's a 2-week course. Yeah. No, nobody's going to give you leave for that long. I certainly won't.
So I think weekend, yeah, or
two split weekends. Now, again, it is primarily the thought process behind this was there were always a group of registrars who found it difficult to access spinal injury rotations, and unfortunately, this is one of those things which, if you don't have a practical working experience, even if it's for a short period of time, it's very difficult to actually, you can read up a lot, you might be very good theoretically with it, but actually dishing out sensible answers and coming up with sensible solutions can get a bit challenging. So we thought if it could be, some simple concepts could be brought out with key aspects of spinal cord injury. I mean, of course, it would just be key aspects of it. It might be useful, and we were just trying to think about what sort of way should we be packaging it. So those are the resources that are there. There are plenty of resources out there. Okay. That would be like the answer sheet, isn't it? Yes, while we are at it. Mm-hmm. Yeah. Yeah. Mm-hmm. So show of hands who think that webinars or just web-based discussions would be useful for a spinal masterclass, for instance. Okay, who would? That would be like kind of a didactic lecture which is recorded, isn't it? Too much hard work there, Candice. Too much hard work. Okay. Okay. Okay, we might do a survey monkey of sorts. It's to get some. Anyway. Not my problem. No clue there. Okay. Okay, I would like to welcome Paula Carroll, who is the dietitian extraordinaire who works at the Prince of Wales Spinal Injury Unit. She has kindly agreed to take time off and come and speak to us about nutrition, and especially in relationship to chronic diseases. So this would be useful information to kind of keep in mind with the multiple areas, not just spinal cord injury, but in general other areas which you will be coming across. The principles of those are important, so don't get bogged down with specific details. You have handouts, we can always refer to that. So just make sure you clarify the principles if you're getting confused. Paula is here for now. Paula, thank you very much.
Thanks, Sachin. Yes, so I'm Paula Carroll. I'm a senior dietitian at Prince of Wales Hospital. Just a little bit about me. I've worked as a dietitian for roughly around 12 years. I've worked in many different clinical areas and in particular focused on general rehab, aged care rehab, brain injury, stroke, neurology, and in the last 3 years I've been on the spinal injury unit at Prince of Wales Hospital. So I was asked to actually prepare a talk on basic nutrition principles with relation to chronic disease in the rehabilitation setting. And what I'd like to focus on first, because I think it's really important, it's one of the most commonly seen conditions that you'll come across nutrition-wise is malnutrition. And that in itself is a chronic disease. So I'm going to be explaining about how to recognise it and the importance of that and how to treat it. Then I'm going to go touch on to basic principles on other chronic diseases like obesity, type 2 diabetes, cardiovascular disease, just 1 pages on gout, IBS, chronic renal failure and pressure injuries. So in most of the literature, the standard malnutrition definition is a state of nutrition in which a deficiency of energy, protein and other nutrients causes measurable adverse effects on body form, function and clinical outcome. Are most of you aware about malnutrition and its prevalence in the healthcare setting? No? Okay, so it's actually a major public health issue. Hospital malnutrition is actually a major public health issue in Australia as well as worldwide. And it largely goes under-recognised, under-diagnosed and therefore under-treated. In the rehabilitation setting, it's estimated to affect between 30 and 50% of our patients. And that's because a lot of our patients have come from acute care, have been transferred from acute care setting, or have come from a community setting where the potential for malnutrition is already there. And then because of a longer length of stay, they're likely to become even further malnourished. In 2015, we conducted a malnutrition point prevalence audit at Prince of Wales Hospital in Sydney Eye Hospital. There were 340 patients in the study, and we did find that 30% of the patients we diagnosed with malnutrition. So that's in line with what the literature says, that between 20 and 50% of hospitalised patients are malnourished. And the prevalence of malnutrition increases by at least twofold in the elderly population and those with chronic diseases. So you'll find the highest level prevalence of malnutrition in the following patient groups, and you can see there that a lot of those patient groups obviously also fall into the rehabilitation setting. So how does someone become malnourished? Well, there's many, the basic answer is the person is not meeting their nutrition requirements. So it's multifactorial as to why that patient's nutritional needs are not being met by the amount of food they're eating. So the first and obvious one is a decrease in their oral intake, and that's multifactorial as well. There's a number of factors why someone is eating less than their body needs. The most obvious one is anorexia or loss of appetite. And then there are a lot of other conditions like particularly pain, gastrointestinal issues like nausea, vomiting. They're all going to contribute to anorexia and further decrease oral intake. We need to also remember there are potential organisational issues that cause patients to actually not be able to consume as much as what they would normally for repeated fasting, for diagnostic tests, failure to record regular weights because we're not able to see a progression and a change in that, not having the resources to assist patients with feeding, and so on. It can also be a combination of other issues like increased nutritional requirements. So if a patient has an infection or a fever or head injury, burns, any sort of major trauma, their nutrition requirements will be elevated. So it's higher than their baseline needs. And a lot of the times, sometimes patients might be actually eating enough, but they're losing it, they're not absorbing it due to diarrhea, vomiting, fistulas, etc. So all those things contribute to malnutrition. So it has a huge impact on patients because it impairs their immune function, so they're more likely to be susceptible to developing sepsis or pneumonia. It impacts on their wound healing and getting those wounds infected. It's actually an independent risk factor for developing pressure injuries, and obviously it's going to cause muscle wasting, weakness, which is going to impair their ability to participate in their rehab program. It also has huge impacts on the healthcare system. So when patients are malnourished, you'll see a lot of an increase in planned admissions, length of stay, rates of readmission, as well as complications for the patient. That all equals increased costs for the healthcare system. So it's estimated that there's an increase in about 20% of hospital costs for a patient that's malnourished. And this is directly linked to activity-based funding. So a diagnosis of malnutrition, when it's correctly documented in the medical notes by a dietitian, is actually something that the coders look for and pick up and actually provide reimbursement for. It's estimated that it's close to $2,000 per admission for someone that's malnourished in terms of extra costs for the hospital. So because of all those issues related to malnutrition for the patient as well as the healthcare system, it's we have policy to help address screen for malnutrition. So are you guys aware of the nutrition care policy? The New South Wales Nutrition Care Policy? So that's all New South Wales hospitals have to follow this policy, whereby all health districts need to have a process of screening in place using a validated tool. It's also in our national policies that we need to screen for malnutrition. It comes under comprehensive care standard. So basically screening for malnutrition in New South Wales hospitals is mandatory. Is anyone aware of the particular tool or know of the tool that we used to screen patients for malnutrition on admission and then repeated weekly? No, it's called the Malnutrition Screening Tool. It's actually inbuilt into the ADRAT admission and discharge form. Some hospital sites have gone electronic, so it's actually been built into the electronic EMR system. And it's a validated screening tool that detects patients that are at risk of malnutrition. It's usually completed by nursing staff, but it can be completed by anybody. And when we did that study in 2015 with across Prince of Wales and Sydney Eye Hospital, at that stage when we had paper-based admission forms, only 30% of MSTs were actually being completed, which is a worry. So this is what the tool looks like. You obviously won't need to do it, but I think it's really important that you guys are aware of the types of questions that are asked on the tool, because a lot of these questions can be incorporated in your clinical practice, particularly if you are suspicious of someone being at risk of malnutrition. So the first question is, have you lost weight recently without trying? And this applies to the last 6 months. We don't want to know what their weight was 20 years ago, or even a year ago. What's happened in the last 6 months? And some probing questions that you could ask is, what do you weigh now? What did you used to weigh? Keep in mind, if a patient has reported a 5% loss in 3 months or a 10% loss in 6 months, that's significant weight loss. Sometimes patients report that they're unsure. I don't weigh myself. My doctor doesn't tell me what weight I am. Ways of being able to get some more information from them. Are your clothes fitting looser? Are your dentures a bit looser? Has anyone commented on you looking like you've lost weight? The second question relates to appetite and eating poorly. So have you been eating poorly because of a decreased appetite? And other ways of getting this information are how many meals are you eating at the moment? How many meals were you eating 2 weeks ago? Are you finishing your meals? Basically, once the answers are scored, and if a patient receives a score of 2 or more, that is an automatic referral to the dietitian, because that places the patient that they have been screened as at risk. So what do we do with that information once we have identified that this patient is potentially at risk of malnutrition? Dietitians used a diagnostic tool called the Subjective Global Assessment, or the SGA. And that's the reason we use that is because it's been validated in a lot of many different patient populations. And again, just like the MST tool that I just showed you, this is not something that you guys will obviously need to do, but I think it's, again, really important that you are aware of the types of information that we do look for and gather when we are making a malnutrition diagnosis. So the Subjective Global Assessment is or the SGA is divided up into 2 sections. We look at a medical history, which is weighted more at 60%. We ask questions about weight, dietary intake, gastrointestinal function, as well as their functional capacity. And then there's a physical assessment component, which is weighted less at 40%. And we look for signs of subcutaneous fat losses, muscle wasting, and edema and ascites related to malnutrition. So looking at the different components of the medical history in a bit more detail, things that you could be incorporating if you are suspicious of someone being malnourished. looking at weight loss in the last 6 months. If it's less than 5% or between 5 and 10% or greater than 10% determines their level of risk. And has their weight changed in the last 2 weeks? Because that will be an indicator as well of higher risk. Things like, the next section is about dietary intake, looking at are you eating less than your normal amounts? And always keep in mind that patients may be kept on extended periods of time on nil by mouth for whatever reason, for numerous reasons. So have that in the back of your mind. Are there any nutrition impact symptoms specifically that are causing anorexia or nausea, vomiting, diarrhea that's preventing them from eating as much as they normally would? The more symptoms and more frequent they have, the higher the risk. And functional capacity, we're looking at what is somebody's everyday activities and has that changed in the last month or two. And we're not looking at, say, for example, if someone's fractured their leg and they can't do their usual activities, we're looking at it related to malnutrition. So has that impacted on, their ability to, with lethargy and fatigue and that sort of thing. Just a note on biochemistry, just to bring it to your attention that when we are diagnosing malnutrition, biochemistry doesn't come into it. And that's because there's not one useful parameter that actually reliably diagnoses malnutrition. So we do get a lot of referrals for low serum albumin and pre-albumin, elevated CRP, but it doesn't necessarily reflect that someone's malnourished. Yes, some people that are malnourished do have high CRPs and low albumins, but some people that are malnourished don't. For example, in the anorexia nervosa population, they can be completely, BMI of 12 and normal albumin. So just to keep that in mind as well, that it indicates the need to treat the underlying cause of inflammation, not necessarily the need for more nutrition. No, our pre-albumin is something that looks at the last 3 weeks, whereas albumin's more of a long-term indicator. But yeah, so we would never say low albumin at risk of malnutrition. We'd look at the whole clinical picture, and it might be part of it at the end of the day, but we wouldn't use it as something So then in the physical assessment, which is weighted at 40%, what we're looking for and things that you can keep an eye out for when you're doing your physical assessments, is there evidence of subcutaneous fat losses, particularly under the eyes? Are they hollow? Triceps and biceps, when you pinch the skin underneath the muscle, is there a good amount of subcutaneous fat, or is it, do your fingers touch? And that's like a good indicator of how much subcutaneous fat stores that they have. We're looking at muscle wasting as well. So starting from top down to the bottom, we're looking at the temple. Is that concave? Are their shoulders nicely rounded, or are they squared off? In malnutrition, you'll see that there's a slight squaring of the shoulders, or it might be severe. Again, is the clavicle scapular, are the ribs protruding? Is there evidence of muscle wasting in the quads? And are the knees bony? So a lot of the time we usually have that nice fat padding around the knees. Are they, has that, and muscle padding around the knees, so has that declined? And also the interosseous muscle on the hand, if there's a concave there, that's also something that we look for. So once we've done both the medical history as well as the physical assessment, we come up with a clinical judgment based on that. So you may have you guys seen your dietitian's documentation, SGA A, B, C? And that's what it means. It means if it's an A, we've determined that they're well nourished. A B, they can be either mildly malnourished or they might be moderately malnourished. And a C is for severe malnutrition. And again, it's really important that dietitians document this clearly because it's directly related to case case mix reimbursement. So why is physical assessment only 40% of the whole assessment? And this is because malnutrition can and does occur in overweight and obese people, not just those with an obviously wasted appearance. Yes. So the general definition for malnutrition, if you look it up, is actually it can be overnutrition or undernutrition. In the so overnutrition in terms of obesity, but in the hospital, when we talk about hospital malnutrition, we're talking about protein energy malnutrition. Yeah. So what do we do with this information? Well, what do we do once we've diagnosed a patient with malnutrition? Dietitians will calculate what their energy, protein and fluid requirements are based on that particular clinical condition that they have, and they will look at what they're actually consuming orally, and then they will try and meet that deficit with first line is oral nutrition support. That involves fortification strategies, texture modification, perhaps the use of oral supplements, but not always, and also addressing any micronutrient deficiencies. Once all these strategies have been exhausted and the patient's still not meeting at least 60% of their nutrition requirements orally, then it's time to consider enteral feeding via an nasogastric tube or a gastrostomy. So we use nasogastric tubes, obviously, when it's 6 weeks or less, and gastrostomy tubes if it's a more of a long-term feeding problem or issue. Parenteral nutrition we only really use if we can't access the gut for ileus, bowel obstruction. It's not indicated in or we really can't get any enteral access. And sometimes we use a combination of all of the above, depending on the patient. Okay, does anyone have any questions about malnutrition? So I'll move on to obesity. Obesity in general is a really, really difficult condition to treat because it requires a multidisciplinary approach. So just to keep in mind that nutrition is only one component of what we need to try and get to accomplish some behaviour change. So what my advice to you would be, the first thing to do if you do have a patient that's overweight or obese is to actually work out their BMI and classify it into, what obesity class does it classify into, and then look at chronic disease risk related to that and actually discuss with the patient what that means for them. A lot of the time patients know they're overweight or obese, want to do something about it, but just don't know where to start. And also one thing to keep in mind with BMI though is that it is limited in terms of its usefulness because it doesn't differentiate between muscle mass and fat mass. So you may have a BMI of 32 elite athlete who's all muscle. You wouldn't necessarily put him into the obesity class 1 category. So to keep that in mind, the limitations of BMI. What's a better indicator of chronic disease risk is actually waist circumference. So greater than 94 for men and greater than 94 for women and greater than, it's greatly increased for men if it's greater than 102 centimetres and for women if it's 88 centimetres. Once that's been discussed with the patient, the most important, that's not the time to refer to the dietitian. That you need to have a bit more of a conversation with the patient because we do in the past we do get referrals for patients that haven't even been asked if they want to lose weight, if that's something that's important to them. So it's really important that you discuss their readiness to change. for their lifestyle behaviours. And some of the following questions are really important to ask. Things like, how important do you think it is for you to make this change at the moment? How confident are you that you can change your eating patterns? And are there any stressful situations apart, like obviously rehab's stressful for a lot of people because, they've had a traumatic life-changing experience, and that's why they're in rehab. So trying to find out what their priorities are and what stage of change they're at is really important. And even if they aren't at the stage of action or wanting to make a change, conveying the message that even small amounts of weight loss improves health and well-being, even just a 5% weight loss. So someone that needs to lose 30 kilos may find that too daunting. So even relaying that maybe 3 kilos is enough to actually show an improvement in sleep apnea, kidney disease, diabetes, etc. In the rehabilitation setting in particular, working closely with the spinal population, it is very challenging to actually initiate weight loss at that particular time. And that's because, like I just said, they've had a big traumatic experience where they've a life-changing experience, and obviously, and nutrition is not always their priority. They have other rehab goals and they have other worries and stresses that are going on. And because of that, a lot of people use food for comfort. I'm sure everyone here uses food for comfort in some way. And this gets highlighted more when you do have that crisis going on. So remembering that a lot of the behaviours are lifelong, so they're ingrained. And also it may not be appropriate to lose weight because the patient might present as obese, but they may be malnourished. So it's not appropriate to start some weight reduction at that time, because a lot of the time as well, when patients have, say, for example, a spinal cord injury, they lose their appetite, and that's related to their low mood. And they may actually present to you malnourished but still obese. With helpful things that you can be asking patients when they are, you do see them using food as comfort, getting them to think about non-hungry eating, and we all do it. Just why do you have that? What are some things that you eat that you know you shouldn't eat? Like, we all know if you want a snack, having an apple is healthier than a chocolate bar, but why do we go to the chocolate bar? So getting them to think about, is it a habit? Is it mood? Is it what's available? Just getting them to even think about it, because a lot of the time they don't. Having said that, it's not impossible to implement some weight loss in the rehabilitation setting. It requires a team effort, and particularly if you do emphasise how important how it will benefit them and their rehab and their functional goals, it may be enough to actually motivate them. And essentially at the end of the day, we want to create a deficit of around 500 calories a day. For a deficit of 500 calories a day over a week should result in at least 0.5 kilo to 1 kilo of weight loss. So rather than rechanging their diet and, saying, okay, if you eat this, this and this for breakfast, now you're going to eat this, this and this for lunch, that's unrealistic. So getting them to choose, and actually it has to come from the patient rather than us dictating what changes they're going to make. It has to come from the patient. Okay, get a bit of information of what they currently eat and say, look, is there that one thing that you can choose that you can make a change? So it might be at morning tea, I don't have that chocolate 3 times a week. I only have it 4 times. You know what I mean? These little changes seem trivial, but over the course of a week and over the course of a month actually make a difference. And a lot of the time, one realistic achievable goal at a time is all the patients can manage, because they've got a lot of other things going on. And also, even just for us, for the general population, when you try and make too many changes at once, we know that it doesn't work. So you just try and pick one thing. just a little bit about the use of meal replacements, like the very low-calorie diets, for example, the OptiFast program. Those diets have their place and they're very useful for patients that are very highly motivated. And I would recommend them only in patients that are going to be an inpatient for at least 3 months. Or for patients that, you know, it's sort of an emergency situation where we need to actually get some weight loss happening rapidly for surgery. They're the times that I would say it's appropriate to use the OptiFast diet, because patients that are sort of on the border, not sure whether I want to start OptiFast or not, tend to fall off the wagon and then have the OptiFast and their meal. So they're just putting extra calories rather than reducing calories. So it's really it's a real mind strength. It's a very, very difficult diet to follow. So when patients are ready to be discharged from rehab, that's the when it's more appropriate to give them more intense weight reduction information and education. Hopefully they're more mobile than what they were when they came in, and they're at a better place mentally. And that's where we provide information on based on the Australian Guide to Healthy Eating. I've got some brochures out there if anyone's interested. I'm not going to take you through all the guidelines and what a SERV is and all that, because that would probably bore you. But it is a very good resource to have. And if you always bring back the patient back to those guidelines, back to X number of serves of fruit, or vegetables and whole grains and low saturated fat diet, that's going to have a knock-on effect on not just obesity, but their lipid profile, their diabetes. These are evidence-based recommendations that promote general health for the whole population. So that's when we would go into all that detail. And that's when we would also refer patients to weight reduction programs in the community. So some hospitals have obesity clinics. There is has anyone heard of the Get Healthy program? It's been developed by the New South Wales government, and it's actually a really good program where you get your own personal health coach, up to 10 free coaching calls, and support over 6 months for weight reduction or any other kind of chronic disease issue. Also, if the patient can afford or has access to a private dietitian or a psychologist, ideally the two together in the app once they get discharged, to provide that ongoing support. Because what you might come across is that a lot of dietitian departments don't provide a weight reduction service in the hospital. Have any of you come across that, where you've made a referral and then you've found that they don't provide a service? Yeah, and that's because it's the resources required to actually provide a thorough service are really intense, and we don't have those resources. Also, weight reduction is shown to actually be more appropriate in an outpatient setting. But it doesn't mean that we can't plant a seed and get the ball rolling while patients are inpatients. So a little bit on diabetes and cardiovascular disease, because the recommendations for both tend to overlap. So with diabetes, we want to make sure they're having regular GI diet for those that have low GI. It's very important to increase fibre, particularly in diabetes, because type 2 diabetes, I guess the biggest risk for developing it is obesity. So it increases satiety, and also the soluble fibre component in fruit and vegetables and whole grains has a cholesterol lowering effect. We want to also provide information on low saturated fat and trans fats. When I say low saturated fat, do you guys know just generally what that means? That just rule of thumb is all animal products contain saturated fat. And there are some plant-based products as well that have saturated fat. And the plant-based ones are mainly coconut oil and palm oil. There's a big craze at the moment over coconut products and coconut oil. Everyone thinks that they're amazing, but it's one of the most high saturated fat products you could consume. So if they do have, if patients do have dyslipidemia, then I would not be encouraging coconut at all. In general, we want to lower the overall energy intake for patients with diabetes, cardiovascular disease, obviously if weight loss is required, because with each kilogram of weight loss, there has been shown to be a 0.1 reduction in HbA1c. And for patients that have high blood pressure, we restrict sodium to a moderate intake of about less than 2,300 milligrams a day. One way of being able to control that and being able to read food labels, so we teach them you could teach them how to read food labels, but the general rule of thumb is any product that has less than 120 milligrams of sodium per 100 grams is acceptable. This is just a visual representation of how low GI products compare to high GI foods, and how we have a nice even distribution of blood sugar levels through the day when you have a low GI. Obviously, high GI products are necessary for people if they're having a hypo, but it's not something we recommend that they have every day. How to work out how much carbohydrate to give a patient. Does anyone know what exchanges are? Carbohydrate exchanges? Yep. So one exchange is 15 grams of carbohydrate. 15 grams of carbohydrate, when you relate that back to food, is like one slice of bread, a medium potato, a cup of milk. So what we do is we work out the patient's energy requirements first, because 50% of those energy requirements, you want them to come from carbohydrate. So if someone's on a weight reduction diet of 1,200 calories a day, 600 are going to come from carbohydrate. Oh, those are exchanges over the day. So there's 3 exchanges in the morning. So for breakfast, 1 at morning tea, 3 at lunch. So it's 45 grams of carb at breakfast, 45 at lunch, 15 at. So that's how we ideally want to spread out the carbohydrate. So once you've worked out that your carbohydrate, you want 600 calories to come from carbohydrate, then you work out, well, how many grams does that mean in terms of carbohydrate? And the way to work it out is 1 gram of carbohydrate is 4 calories. So you do that equation, comes to 150 grams of carbohydrate that person needs over the whole day. Then you divide the 150 grams of carbohydrate by 15, because that's per exchange, and you're left with about 10 exchanges. Then you know how many exchanges you want to give the person for the day, and you want to spread those out. So you might do 2 at lunch, 2 at dinner, 2 at breakfast, and then 1 in between. So that's just a general rule of thumb, how you would do it. You'd obviously individualise it for each patient, depending on if patients are having hypos in the morning or hypos at night or whatever. But that's just a general way that you would try and spread exchanges over the day. And again, making sure that the carbohydrates you are recommending are low GI. So just one slide on gout. Obviously, it's pretty much managed medically, but if you need, if patients need some extra advice, being within a healthy weight is actually beneficial, because it's more common in people that are overweight. Getting them to reduce alcohol, particularly if they do drink beer and spirits, because this can greatly increase uric acid. Making sure they keep hydrated, they meet their fluid requirements, because it helps to dilute uric acid levels. And also looking to decrease purine-rich foods in the diet because they actually form uric acid in the body. Things like meat, seafood, and yeast-containing products. Irritable bowel syndrome. So some people alternate between diarrhea and constipation and bloating. So it's really symptom related as to what advice you provide. If patients are having a lot of diarrhea, you would advise them to limit their caffeine intake, reduce their diet products because a lot of diet soft drinks, mints and gum contain sorbitol, mannitol, xylitol, and that really can irritate the gut. Making sure that they're replacing the fluids that they're losing through diarrhea, and it can be helpful to limit rich and fatty foods as this can worsen the symptoms. If patients are experiencing bloating or constipation, recommending that they reduce gas-producing foods like beans, pulses, again, diet products, and anything from the brassica family like cabbage, broccoli, and so on. Again, ensure they've got adequate fluid intake. If someone's not meeting their fluid and fibre intake, then that can exacerbate constipation. And increasing their fibre intake, so swapping white products for whole grain or brown products, and increasing fruit and veg. They're good starting points. Some other things that you can consider are probiotics. There's not a good amount of evidence, but some people have reported some benefit, so it's worth trying. Keeping a food and symptom diary and initiating a low FODMAP diet. Chronic renal failure is very, very individualised. Usually the dietary intervention is based on the cause of the renal disease in the first place. So we would treat diabetes or hypertension or both. And protein intake is just like the general population. There's no restriction. So it's a moderate intake of 0.75 to 1 gram per kilo of body weight. And again, limiting salt is common in chronic renal failure. And finally, pressure injuries. So malnutrition is a key risk factor for developing pressure injuries and also in the delay of their healing. In that audit that we did, we found that 50% of patients that had a Waterlow score of 10 or more, so that were at risk of pressure injuries, were had a malnutrition score of 2 or more, which meant that they were at risk of malnutrition. Being overweight or obese also puts patients at risk of developing pressure injuries. So if patients have a pressure injury of a grade 2 or above, then their need for protein and energy is increased. They need at least 30 to 35 kilocalories per kilogram per day of energy, and they need at least 1.25 to 1.5 grams of protein. That depends on the grade of pressure injury and clinical judgment. It's also really important to make sure that they are meeting their fluid requirements because this helps promote nutrients to the area. And it's important to rule out any micronutrient deficiencies, specifically replacing zinc, vitamin C, A and selenium if these come back low. Arginine is used for pressure injuries 2 and above. It's an amino acid which also has a role in pressure in wound healing. It brings nutrient flow to the area. One thing to keep in mind though, when patients, what do we do if a patient is overweight or obese and they need this extra energy and protein to heal their pressure injury? It's very challenging because I guess the clinical priority there is to heal that pressure injury. So at times they will gain weight and that's unavoidable. But it's very challenging to get the protein up, to get the energy up and not gain weight. So just to keep that in mind.
I just want to clarify something. There's also a lot of interest in fasting. If somebody is obese and on a fat stove, is it necessary to supplement the energy that from they just step onto their fat resources and she's going on stuff like that.
I think because muscle breakdown will happen.
That's what the protein is for.
Yeah. I don't know, because it's hard to increase protein intake without increasing the energy at the same time, unless you do a pure protein powder. I get your point, but it's there's just not a lot of product menu items or products, nutritional supplements. A lot of nutritional supplements will also have a lot of energy. So the only thing that's really that I would recommend in patients that are obese, so we don't want that extra energy, we want that higher protein, is something like Benny protein, which is a pure protein powder with 6 grams of protein per scoop and not very much energy at all. But that's not very palatable, so compliance is low, yeah. That's not my area of expertise, so I'm sure there are studies out there, but it's not something I have focused on, no. Yes, Burns patients have even higher needs for protein, so they'd be up to 2 grams per kilo of body weight because of the protein losses through the burns.
What are accessing supplements for patients to develop more supplements? What are the systems that are available?
Yeah, so what we normally do if a patient needs to go home on a nutritional supplement, then it's called home enteral nutrition, and it's a scheme where if someone's been seen by a dietitian, they can actually have a prescription written out by that dietitian and they get a special price. So, through Bright Sky or different, depending on the supplement. So, if they're Sustagen comes from Nestle, Ensure comes from Abbott, so they use different suppliers. We write out a script and then they get a special price it's a much cheaper price. It's the hospital, little bit more than the hospital tender, but much less than if they were to go and buy something at the pharmacy. So if a little tetra of Ensure Plus, it's $1.10 or something through the HEN scheme. If you go and buy a tetra from the pharmacy, it's probably about $5. So, and the good thing about that scheme is that it gets delivered to their home. So cartons of product get delivered to their home, so they don't have to go to the pharmacy and collect it like you would say DBA products.
Is there a cap on that? Or
No.
as long as they
Yeah. Yeah, so the script is up to, it can be ongoing. So patients that are going to be lifelong enterally fed, we say that it's an ongoing script. Others, we might think that they only need 6 months, so we'll put 6 months on the script because we do that on purpose because we want them to come back and be reviewed. We don't want them to continue taking this when it's not necessary. And it's a way of us flagging a review. I think some patients now are also putting down, like particularly enterally fed patients, on the NDIS scheme so that it's part of their scheme, so they're getting equipment and things like that paid for through NDIS. That's it.
messages from textbook reading. What do you guys would be recommending or is it important or and that's not something I never agree with. They are just struggling to kind of figure out what's happening with them in their lives at the moment. So getting them to think about that and documenting that so you can have that discussion see them for the first regularly, and then provide them with appropriate resources. So accessing diabetics in the community, what are the interests?
Yeah, so usually if patients can't physically come in for an outpatient appointment, so I can only speak for Prince of Wales Hospital. So Prince of Wales Hospital has an outpatient clinic, a general outpatient clinic where we accept most referrals except for weight reduction because we don't have the resources for that. We don't accept people with diabetes because we do have the diabetes centre that the dietitian there takes care of that. And if patients are immobile and can't actually come in, there are community options where community dietitians can go to their house and do a home visit. They're very strict with the criteria though, so those community teams, but if they meet the criteria, that's an option. But there are, so sometimes there are gaps in services, but we try and work around it. So if I can't get a community dietitian to see the patient, I might do a phone review. There's always ways to get to the patient. Yes, yeah. Yeah, I know RPA has an obesity service, but I think they're like chock-a-block and takes a long time to get in. But they're not like obesity service, and there's one at St George as well, but not all hospitals have that service.
I have a comment on the last class. Research on that part of my case. The fasting approach is that there are particular dosage of fasting which seems to have that beneficial effect coming, and there are a few different formulas on there. There's a very useful documentary in the BBC which looks at those aspects. Could be a more recommended practical aspect. That is mainly something which you can recommend for anybody, maybe on somebody acting out of metabolic problems. So that's mainly for that. The main benefit that seems to come out of these changes, dramatic changes with increasing resistance, and also comes across program follow that exercise plan. We get similar changes between high duration of exercise. So that's a very dramatic change coming from very little. Again, it's not sustained to stop that after 2 weeks of reverses. And chronic pain seems to behave exactly like chronic disease as far as nutritional performance goes. So it seems to have a very good dose. And there are a lot of papers that show that it generates a state of inflammation. It's not that passive inflammation, it's an inflammation state, which makes individuals more susceptible for chronic pain. I'm talking about the amendment of nutrition. Thank you very, very much for.
Thank you.
Might take a small break here before the game starts.